Welcome to This Week in South Carolina. I'm Gavin Jackson. With cold and flu season heating up, state epidemiologist Dr. Linda Bell breaks down what we should expect this winter. But first, Dr. Eugene Chang, a maternal fetal medicine specialist at MUSC, discusses the rising issue of maternal mortality. Dr. Chang, thanks for joining me.
Yeah, happy to be here.
So, Dr. Chang, I want to ask you about maternal mortality rates in our state. In 2019, there were 66 pregnant women who died, 22 of which those deaths were determined to be pregnancy-related. 70% of pregnancy-related deaths occurred during the postpartum period. Can you tell us about why that's always the case and what's driving this?
Yeah, that's a great question. I think it's a lot of factors. I think the first thing, and something that I've learned by participating in review of all these mortalities, is that, most of the time for an obstetrician, when you hear about a maternal death, the things that most of us picture is a patient who has severe bleeding or something like a heart attack or stroke right around the time of delivery. And certainly those things can happen, but thankfully, to be honest, I think we're making a lot of headway, particularly in the area of hemorrhage. And so what's happening is now we're recognizing, if we spread out, sort of looking at pregnancy as a factor in a patient's passing away, and we take patients a year out from their pregnancy and kind of look and see what happened and led to their death, then we do see pregnancy as an issue. And so in the postpartum patients, certainly things like uncontrolled blood pressure issues can lead to death, but a big chunk of what we see is related to psychiatric disease and substance abuse. And so a lot of overdoses, unfortunately. And, those are all things where the question is really, is pregnancy a driver of that death? No, but is pregnancy something that was a big stressor on the patient that led them to that point? The answer is probably yes.
Mm-hmm. Yeah, so you're saying the top underlying causes of these maternal deaths are cardiomyopathy, mental health, and hemorrhage. When you do cardiomyopathy and cardiovascular conditions together, that accounts for 1 in 4 deaths, according to some reports from DHEC.
Right.
So how do you get those numbers down? Is that more when it comes to comorbidities with the patient?
Yeah, so the cardiomyopathy part is tough, because there are patients who develop cardiomyopathy, and I don't know that we have any way of predicting who the patient is that's going to develop that. Where I think we struggle is patients will develop something called a peripartum cardiomyopathy, and a lot of times they'll have recovery and actually get better. The problem becomes when they get better and they get pregnant again, they have a risk of recurrence. So, I think addressing, in a sensitive and an honest way with patients, like what their childbearing, plans are in that particular group is important. And then in general, just addressing cardiovascular disease before pregnancy is the most ideal thing we could do. In practice, it doesn't work, because in practice, what we typically see is patients show up pregnant, you take a history, and then you find they've got some cardiac issues. Most commonly hypertension, so high blood pressure. And again, the good news with that is that can be treated. So, the challenge really with respect to heart issues is identifying the patient. And, there are definitely patients we feel like should never be pregnant with certain heart conditions. There are patients with heart conditions that we see that we feel like if they can get tuned up, if you will, prior to pregnancy, they would do better. And so that's the issue, is kind of seeing the patient before. It's a hard thing to do, honestly. If you're a cardiologist following these patients, your focus is on the heart, and understandably not always on the patient's desires for childbearing. So it's just something that we're trying to do, is to raise awareness across the board on these issues.
I was going to say, is that your message to women who are maybe thinking about becoming pregnant, if they do have some, hypertension issues, cardiovascular issues, that they should really be aware of that before going forward with, a complicated thing such as pregnancy?
Yeah, I think the best thing to do, if you're a woman contemplating pregnancy and you have any sort of medical condition, the first thing to do is always bring it up with your doctor. Hey, I'm thinking about getting pregnant. And so there are a lot of patients that have fairly straightforward medical problems that can be addressed by their primary care physician or their specialists that don't necessarily need to involve a visit to a maternal fetal medicine specialist right away. But as long as it's addressed, they'll do well. And there are other women who actually need to be sent to us in our minds. And yeah, getting those patients to the right place is really important. And so the only way to do that is to communicate.
Yeah, because it can lead to complications later on. I mean, my cousin, for example, she was pregnant. She had preeclampsia during delivery and was touch and go there for a little bit. Now she's talking about wants to have another baby. What's the advice for folks like that? Should they be having another baby if there's complications in one pregnancy?
Yeah, it all depends on the complication and the situation. The one true is in obstetrics is if it's happened before, you're at risk for having it happen again. So that's sort of the bad news. The good news is for a lot of conditions like preeclampsia, even when it recurs, it tends to be less severe. There are things we can do to reduce the risk of preeclampsia. But yeah, I think the interesting thing with women who have complications like preeclampsia is that pregnancy, for the most part, is something that occurs in healthy young people. Right. And so you go through pregnancy, you do all the right things, and then you get really sick. And then your sense of well-being actually just evaporates, because all of a sudden you went from being well to not well. And, that can be traumatic for lots of patients. And I think, again, communication is important and understanding, the questions to ask. And I think if you're pregnant and if you've ever had a complication with pregnancy, the conversation with your OBGYN should be like, hey, I'm thinking about getting pregnant again. Is that a good idea, bad idea? What's the chance of whatever complication I had recurring, and what can I do about it?
Mm-hmm. Yeah, Dr. Chang, you were just talking about there about how that well-being can transition there for some of these complications. So is that maybe what also leads to some of these mental health issues that we see postpartum? A lot of these deaths were also mentioned to be preventable too. So is it maybe just a whole patient approach too, especially after birth?
Yeah, I do think it's a whole patient approach that is really important, but I don't think so. I think a lot of the mental health related deaths and the substance abuse disorder related deaths or patients who came into pregnancy with those issues, a lot less common for a patient otherwise healthy without those diagnoses to develop those diagnoses. Can it happen? Yes, but those are a little bit different, and those patients are a special population because they're hard to take care of in the sense that resources in the state and the community aren't as robust as we'd like. Thankfully, at MUSC, we have a group of psychiatrists that are very interested in women's behavioral health and reproductive behavioral health, and recognize the strain that pregnancy puts on someone. And they've done a lot of outreach and really have provided a remote, like a telemedicine platform for patients, and really they reach patients across the state now. Mm-hmm. That's been good.
And Dr. Chang, you've been practicing for many years in South Carolina. I want to ask you about the 6-week abortion ban law that got upheld by the state Supreme Court. I don't want you to get too political. I know that's not your job, but I just want to ask you what you're seeing. It's been 2 months now. Are women nervous? I know there's some exceptions for fatal fetal anomalies in there, but that takes a lot of hurdles to clear in terms of whether someone has to give birth to a child with birth defects. What's it like right now on the front lines 2 months into this?
Yeah, I think it's difficult. I think, none of us really know how to navigate what's going on now. I think the problem as a physician is understanding, what is really lethal, for a baby, and, what are things that are, problematic for moms to the point where a termination of pregnancy is okay. It's I think the legal world and the way a law is written is inherently very different from, how we think in medicine. And I think marrying the two presents a challenge. And, obviously the threat of being charged with a felony is something that weighs on all physicians. So I think it is tough. We're all trying to figure it out. It's frustrating in the sense that, you feel like you kind of understand. I mean, I feel like I understand where the legislature is coming from, in the ban. But I do think they're just things that we're a little bit more poised to understand, seeing these problems day in and day out. And, I don't know really what the solution is. I do think somehow physicians need to be more involved because, like I said, the laws are written with lawyers in mind, but not physicians in mind. And it makes it really hard to provide care.
Have you had any complicated situations in the past 2 months due to the law?
I have not personally. But yes, I mean, part of my job is, fielding a lot of questions. And then we get a lot of questions about, just what, like I said, I think defining lethal is tough, and that's probably the question that comes up the most. I've seen a baby with this problem. Is this lethal? And the answer is, well, it's a complicated answer. So it makes it for a tough discussion.
And Dr. Chang, I just want you maybe, forecast or maybe estimate. I mean, there were 416 infants who died within the first year of birth. That's our infant mortality rate in the state. That's 7.3 per 1,000 live births. Do you think that rate might go up as a result of this law? Can you even guess that?
Yeah, there's no way of knowing because, I would anticipate the number would go up because what I would think would happen is that, patients with babies with anomalies that were really severe who would have formally terminated the pregnancy would be carrying those pregnancies, deliver those babies, and then they would pass away. So, that number may change. Patients still can leave the state. So the part we don't know about is, how many patients will leave the state to have a procedure done. So I would think the answer is sort of yes, sort of no. And, it's tough. I think it probably this little question points out one of the big flaws with the way we track things. If that truly represents an increase in infant mortality, it sucks that the number is going up, but I think the biggest question is, are we as healthcare providers not doing our job? I think that the way I think about this is if I see maternal mortality rates are going up, I think, well, what can I do to make things better, right? I think if you're a pediatrician and you see an increase in infant mortality going up, your thought is, what am I not doing? What can I make better? The truth is, if you see an increase and it's related to this particular group of patients, patients with fetal anomalies that pass away, I don't know what you do about it.
Yeah, and this also
it's kind of right. It's not actionable, really, right, from a pediatrician perspective.
And it comes at a time too when there's a lot of counties in our state that don't even have access to OBGYNs like yourself too. So that kind of compounds this entire situation.
Yeah. I think, trying to be a little bit stoic about all of these things, we try to control the things we can and understand that part. And I think there are a lot of things that, as an OBGYN or maternal fetal medicine specialist, we can do. I mean, the challenge of healthcare deserts in this state is tough. I think smaller counties, probably don't have enough in terms of population to support a hospital. So I don't know how realistic it is to have a hospital in every county. I do think, we need to figure out ways to get healthcare to patients a little bit better. Now that, they still probably will have to travel to a hospital, but, I think the thing that COVID showed us is that we can do a lot more with teleconferencing, televideo, and televisits, if you will, that would be beneficial to patients.
And Dr. Chang, we're going to have to leave it there. That's Dr. Eugene Chang. He's an OBGYN at MUSC. Thank you so much, sir.
Yeah, you're welcome.
Joining me now to discuss the respiratory virus season is state epidemiologist Dr. Linda Bell. Dr. Bell, welcome to This Week in South Carolina.
Thank you for having me, Gavin. I appreciate it.
Great. Well, we have a lot to talk about, obviously, with respiratory viruses, but let's start with the flu. Everyone knows about the flu. It's always here every season. But the 2024 season is officially underway right now, and it comes on the heels of a really bad 2023 season. But first, just tell us what folks can be doing in preparation for the flu season and what the trend is looking like so far.
Yes, thank you. We do want to make sure that people are informed of the potential increased activity of the flu virus. And as you said, we've already started in the flu season, which officially sort of kicks off the beginning of October. But we know that flu activity can be unpredictable. So it can increase, as we saw last year, a huge surge in the very first week of flu season. And flu activity can vary in its intensity anytime between October and actually flu season ends in May. We generally see the highest activity in December through February, I would say. But because it's unpredictable, we really encourage people to get their flu vaccine, an annual flu vaccine, well in advance of when flu activity is expected to increase, to make sure that they're protected before they're exposed. And what we want to inform people about with the flu vaccine is that it actually takes your body about 2 weeks to mount a full, strong response. And so that's what we mean about what people can do to be prepared. People often ask, well, why do I need to get a flu vaccine every single year? And that's because the virus changes a little bit from year to year. And we want to make sure that people receive the vaccine that is best matched to the currently circulating strain. That's one reason. And the other reason is that protection against the flu is not really durable. So it wanes, it decreases over time. So it's very important for people to get an annual flu vaccine to make sure that they're best protected against the currently circulating strain and that they have the strongest possible protection in advance of being exposed is really the best option.
So Dr. Bell, when we look at this year's flu vaccine, do we know how effective it is yet? Have we any studies, any ideas when it comes to these strains?
So we have some indication. The way vaccine manufacturers design the flu vaccine from year to year is that they actually conduct surveillance for flu activity in the southern hemisphere. So in the southern hemisphere, their flu season is April through October. So they monitor the most common circulating strains in the southern hemisphere, and then they develop vaccines to be what is best well matched to what's circulating in the southern hemisphere, because that's generally what we see in the northern hemisphere by the time it gets around to us. And so what we've seen so far from that surveillance in the southern hemisphere is that the vaccines that are currently available in the United States are pretty well matched to those that are circulating in the southern hemisphere. So we think that it will offer good protection. Another thing that we did see in the southern hemisphere was that they actually saw higher rates of children being affected with the flu. But we believe that's primarily because many children did not get vaccinated in the last flu season. So from one year to the next, even though we do recommend an annual flu vaccine, you do get some immunity from previous exposure. And that did not happen for many reasons. Actually, the protective measures that we took against COVID prevented people from being exposed to other respiratory viruses, including the flu. So a lot of people don't have strong natural immunity. But we think that the current flu vaccines that will be offered in the U.S. this year, this flu season, will be a pretty good match.
Yeah, Dr. Bell, that kind of goes back to a question I have about the last flu season we saw with about 3,400 hospitalizations and 162 deaths. Those metrics were far above their 5-year averages, and that was for the 2023 seasons. Do you think that was more of a result of folks coming out from COVID and kind of going back to daily life? Was in the post-COVID era that we're in right now? Is that what you attribute to that spike to?
We do in part, and also we want to remind people that when we were in the throes of the COVID pandemic, in those 3 years prior, we actually had very mild flu seasons. So that natural immunity that I mentioned to you that comes from exposure didn't occur because it was just very mild flu seasons. So for those reasons, a lack of natural immunity, lower uptake with flu vaccines, we believe are strong contributors to that really alarming surge that we saw with the beginning of the flu season last year. It did taper down pretty quickly, but I want to take every opportunity to remind people that one flu season to the next They all look different. We have seen rapid increases and declines only to be confronted with a second surge in a flu season. That often occurs with the type B influenza strain. So the underlying message is, as best as possible, let's just be prepared with coverage with the flu vaccine instead of trying to rely on how severe the flu season will be or taking chances on the risk of exposure.
And when you look at DHEC data, let's pivot to COVID really quick. COVID-19 right now is a little bit more prevalent than the flu circulating. Would you say we have like hospital admissions, I think around 250 a week, and hundreds of ER visits weekly too. Dr. Bell, do you think COVID is the biggest respiratory virus threat for the state right now?
So it is currently, because as I know we'll get to this, looking at flu and also RSV, the most common hospitalizations that we're seeing are attributed to COVID. We also do surveillance for outbreaks in congregate settings. So we are monitoring flu activity, COVID activity, and RSV activity in schools, in nursing homes, and other settings. And the highest number of outbreaks reported in those settings is also due to COVID at this time. We are seeing a little bit of an uptick in flu, but not really significant, but we really need to be monitoring that because we anticipate it will increase.
Mm-hmm. We were talking about the effectiveness of the flu vaccine. Talk to us about this new COVID vaccine and how effective that is, and who should get that vaccine.
Yes, thank you. As most people know, the FDA has recently approved an updated COVID booster, and the CDC is recommending that now for everyone 6 months of age and older. The reason for that update is because the predominant circulating strains or variants of the COVID virus have changed pretty significantly from the previously available vaccines. The updated booster is pretty well matched to the predominant strains that, or we refer to these as variants for COVID, that are most commonly circulating now. So we are seeing that gives very good protection against severity of illness. So people may still get an infection, but it's very good at preventing hospitalizations and preventing deaths. And so our goal now really is to reduce the severity of the impact of COVID by reducing hospitalizations and deaths. And people who are most likely to have those severe complications are people who are unvaccinated.
Mm-hmm. Yeah, Dr. Bell, I mean, I've had COVID before, I've been vaccinated before, but now we're saying to lessen the severity of any potential infection, I should get the shot again.
That's correct, because people do question, well, I got the vaccine and I still got COVID. Well, it's not 100% protection. No vaccine offers 100% protection, and what we really bank on is our goal is to avoid severe illness, mm-hmm. and that is what those vaccines really are best at.
And Dr. Bell, we have about 2 minutes left, and I want to ask you about RSV because there's a vaccine for that too, but that's for different age groups. Kind of talk to us about what RSV is and why folks should be getting that shot.
Sure. Quickly, RSV is something we haven't paid as much attention to in previous years. Respiratory syncytial virus is what RSV stands for. And many people don't know that RSV is responsible for a significant number of hospitalizations in older adults each year and deaths. So there's a new vaccine that's been approved that is recommended for people over the age of 65. Additionally, young children are severely impacted and are at highest risk. So there is a new vaccine for children. And there is actually a monoclonal antibody that is recommended for very young children who cannot yet be vaccinated. So that is from birth up until 6 months in the first RSV season. And then the other exciting thing that I'd like to add is that there is actually vaccination recommended for pregnant women. So if they receive the vaccine in the last weeks of pregnancy, between 32 and 36 weeks of pregnancy, those maternal antibodies will protect those young babies in the earliest weeks of life and have been shown to prevent hospitalizations in those babies. And so these vaccines are available, and then that monoclonal antibody, which gives antibodies to offer protection for those very young babies, And so that's what I really want people to know about for RSV. It is an unrecognized cause of severe respiratory illness.
Gotcha. And really quick, 30 seconds, Dr. Bell, what should people be doing right now, wrapping up for preparation for this season?
Sure. Well, let's not forget about other measures that protect people against illness. Simple things like washing your hands. If you are sick, stay away from others. Protect others. Don't send your kids to school. Don't go to work. Get tested so that people are aware of which specific agent they may be affected by, because there are treatments for each of those, separate treatments. And so we want people to just be vigilant about hygienic practices, stay home if you're sick, and please, the final message that I would like to offer is please consider vaccination against all of these illnesses, because it can really significantly change people's lives.
Very good. Yeah, I'm always washing my hands, especially now more than ever in this cold and flu season. That's state epidemiologist Dr. Linda Bell. Thank you so much for joining us, and thank you for all you do to keep our state safe.
Thank you for this opportunity.
To stay up to date with the latest news throughout the week, check out the South Carolina Lead. It's a podcast that I host on Tuesdays and Saturdays that you can find on southcarolinapublicradio.org or wherever you find podcasts. For South Carolina ETV, I'm Gavin Jackson. Be well, South Carolina.